Good afternoon, everyone. My name is Alex Lamont, and I am a Legislative and Policy Coordinator for your New York State Association of Counties. On behalf of our President, Jack Marin, and our Executive Director, Stephen Aquario, I want to thank you for joining us this afternoon for a virtual fall seminar workshop about using testing to slow the spread of COVID-19. Our 2020 virtual fall seminar is taking place throughout the month of September and into the first day of October now, and it includes nearly 20 workshops and meetings designed to bring the latest information on the issues facing today's county leaders to you. We thank you for joining us as we move counties forward together, and we encourage you to use hashtag #CountiesForwardTogether to tweet about what you hear throughout the conference. This afternoon, we're here to talk about COVID-19 testing. Readily accessible testing is critically important for identifying, isolating, and treating people who are infected with COVID-19. This workshop will focus on how diagnostic and antibody testing have changed since the start of the pandemic and what innovations our counties and universities are using to expand and improve COVID-19 testing across the state. We're happy to be joined this afternoon by a great panel of speakers. The first is Dr. Gail Burstein, who is the Erie County Commissioner of Health and a clinical professor of pediatrics at the Jacobs School of Medicine in Buffalo, New York. Dr. Burstein is currently devoting Erie County public health efforts to control COVID-19. She also continues to work on strategies to expand substance abuse treatment access and prevent opioid-related deaths. She participates in the writing National Adolescent Healthcare Guidelines and has published scientific peer-reviewed journals. We're also joined by Dr. Sherlita Amler, who is a physician and has served as Westchester County's Health Commissioner since October 2011. A former CDC medical officer, she has been leading the county's public health response to COVID-19 since the beginning of 2020, even before the first cases were identified in New York. She initiated contact tracing as soon as Westchester's first COVID-19 case was confirmed on March 3rd. This was only the second case in New York State. In addition to being a licensed physician, Dr. Amler is also a licensed registered nurse, a certified emergency manager, and has 39 years of public health experience at the federal, state, and local level. Finally, we're very happy to be joined by Brittany Kamish, who is an assistant professor in the Department of Public Health at Syracuse University. Dr. Kamish has a PhD in global disease epidemiology and global disease epidemiology and control from Johns Hopkins School of Public Health. Her areas of specialization include infectious disease epidemiology, vaccine development and epidemiology, and maternal child care. For the past 8 years, she has been focused on the elimination of hepatitis in Asia, where it causes substantial maternal mortality. Before we begin, I'd like to take a minute to thank our sponsor, United Healthcare, for sponsoring this session. United Healthcare is dedicated to helping people live healthier lives and making the health system work better for everyone by simplifying the healthcare experience, meeting consumer health and wellness needs, and sustaining trusted relationships with care providers. They offer a Group Medical Advantage PPO plan, which is a single platform designed with broad national access. It's tailored to provide members with the value and flexibility to meet the healthcare benefit needs of retirees. Retirees have access to health benefit programs and services designed to make a positive difference in their life, such as health and wellness programs, chronic care management programs, acute illness, and return to health programs, and more. If you have any questions throughout these presentations, we encourage you to type them into the question panel, which you can find on the GoToWebinar dashboard on the side of your screen, and we'll take them up after the 3 speakers finish their presentations. So at this time, I'd like to thank our speakers again for joining us. Thank you, Dr. Burstein, Dr. Amler, and Dr. Kamish. And at this time, I will turn it over to Dr. Burstein. Thank you.
Thank you. So good morning, everyone. And I'm here to talk about COVID-19 testing. So can I have the next slide, please? So, yeah, thanks. So first, I'm just going to give an overview of the different diagnostic testing platforms that are available to us in New York State, just so you understand which tests are what and how they perform and their limitations. And then I'll describe just briefly about how we've been doing testing in Erie County for COVID-19. Next slide. So there's actually two different categories of the SARS-CoV-2 diagnostic tests. There are the molecular diagnostic tests and then the antigen tests. So the molecular diagnostic tests detect the SARS-CoV-2 RNA. So they're looking specifically for the RNA. This is mostly done in clinical laboratories. I'm sure you've heard about the reverse transcriptase PCR, the polymerase chain reaction test that many of us are using or have access to. And then also more recently, there is a point of care test, or more of a lay term, a rapid test of a molecular diagnostic test that the governor has been using, especially in our area with SWAT teams to help us respond, which is called the ID Now test. So that's something, a test that can be done rapidly and in the field. You don't have to send the specimen to a clinical laboratory and wait for those test results. So that's the advantage of that. And then the second category are antigen tests. So those detect SARS-CoV-2 antigen, which is a protein on the virus. These are all point of care tests or rapid tests that can be done in the field. Next slide, please. So let me dive into a few more specifics to differentiate between the molecular diagnostic tests and the antigen tests for COVID-19. So on this table, I'm looking at, the middle column is looking at the indications for the molecular diagnostic test, and then the column on the right corresponds to the antigen test. So first, for the intended use for both tests is to detect a current infection with COVID-19. As I mentioned earlier, the molecular diagnostic tests are looking for the viral RNA, and then the antigen tests are looking for the viral antigen, which is a protein on the virus. So the types of specimens that can be collected with a molecular diagnostic test are actually pretty varied. Those have been around longer, and so we can use nasopharyngeal swabs, just nasal swabs, just a swab in the nose, either provider collected or self-collected. There are throat swabs are validated, sputum, spit, or saliva, which is also self-collected. As opposed to the antigen test, those are all nasal or nasopharyngeal swabs. So I think the big difference comes in with the sensitivity. So the molecular diagnostic tests are highly sensitive. And of course, any test the sensitivity will vary depending on where you are in your course of infection. So if you were infected yesterday and you had a test today, it probably wouldn't show up because you wouldn't have enough virus to detect by either a molecular diagnostic test or an antigen test. However, a week after you were infected, you should have a high enough viral load to be detected by either a molecular diagnostic test or hopefully an antigen test. But definitely the molecular diagnostic test that looks for the RNA is more sensitive and can detect lower viral load, so a smaller number of viruses compared to the antigen test. But they both have their place, and they're both good diagnostic tests for detecting COVID-19. So in terms of the specificity, both tests have good specificity. So that means if you get a negative test result for either of these tests, with the sensitivity, you might be worried that, especially with the antigen test, that maybe something was missing. However, if you get a positive test, you can feel very confident with either test that you really do have the infection, and that's a solid positive. You don't have to worry about getting a confirmation test. And then another difference between these two tests is where they can be run. So most of the molecular diagnostic tests have to be run in a clinical laboratory. There are a couple, such as the ID Now, that are CLIA waived, so they're point of care tests or rapid tests that can be run in the field. And then all the antigen tests are pretty much CLIA waive point of care tests or rapid tests that can be run in the field or a doctor's office and do not need to be sent to a clinical laboratory. So in terms of the turnaround time, that's also a big difference between these two types of tests. With the molecular diagnostic tests, oftentimes, for the most part, they need to be sent to a clinical laboratory, and the turnaround time can vary between days to, except with the ID Now test, those results are available in 15 minutes. Whereas the antigen test, those are all rapid tests that the test results should be available within 15 minutes. And then a cost is also a difference. So the molecular diagnostic test, because it's a clinical laboratory test, the cost is a little bit more. It's kind of an average lab test, like $100 or maybe a couple $100, depending on what the laboratory charges, versus an antigen test, which should be much lower cost, $20 or somewhere around that. Next slide, please. So let me give you an overview over how we have been using our tests and how our testing program developed. So just a background on Erie County, if you're not familiar with us. So we have a population of about 920,000 people. We have, it's a large county and it's very diverse. We have both urban, suburban, and rural communities. We have a public health lab as part of our health department, and that's actually part of CDC's laboratory response network. So we get directly from CDC tests, like we have their first generation and now their second generation COVID-19 tests, and they also supply us with the other testing supplies, the consumables, to be able to run those tests. So that's an advantage to us that we don't have to compete in the market to try to purchase these test kits and the additional supplies. So our public health lab is now offering and has started offering from the very beginning the reverse transcriptase PCR that's run in the public health lab. And then also under our public health lab license, we're able to offer the ID Now test, which is run in the field. Next slide, please. So just in terms of what we're doing with our PCR testing from our public health lab. So right now we have a good supply of tests. So we have drive-through specimen collection clinics in different parts of Erie County 3 times a week. So we have a location in the north, a location in the city, and then the location in the southern part of Erie County. So these are all appointments are required because you know that COVID-19 tests are pretty hot, they're in demand. And so our laboratory, because of staffing, can only run about 150 to 175 tests with each clinic. So we do limit the number of people that can get tested. We average about 500 to 550 PCR tests each week. We have a very good turnaround time. Results are available in 3 to 5 days. And right now we don't have any criteria for the PCR testing. It's basically anybody who feels that they have been exposed or they're symptomatic or they want to get a test to know their status. And then here is a picture of our rapid testing specimen collection team in their PPE. Next slide, please. And then from our IBD Now tests, these are tests that we're doing in the field. So we are very fortunate to receive on loan 6 machines for the ID Now from the New York State Health Department. So we really want to thank them for that. So what we're doing now is a strategy to be able to keep students who are attending in-person classes and teachers that are teaching in the schools in school when possible. So we really devoted this resource to testing symptomatic students and teachers. So we have 6 machines total on loan. So what we do is every day we have 2 machines stationed at the different parts of the county, one in the north towns, one in central county, and one in the south towns. And they do testing on site. Each person takes about 15 to 20 minutes to run a test. And so they walk away from the testing experience with their test results in hand. And again, these are very high demand. I never knew there were so many kids in Erie County that had respiratory symptoms every day. And so they are all trying to get tested with our ID Now machine so that they can get back into the classroom. So appointments are required. So the criteria for our ID Now tests are symptomatic pre-K to grade 12 students who have classes in a school setting. Many of the schools now have hybrid models where part of the week they're in class and part of the week they're out of class. So if they're in class any part of the week, we want them to get back into the class. So we allow symptomatic students to get tested. Also, we're testing symptomatic school staff, and they have to show an employee ID. And we're not offering testing to people in quarantine because they have to stay out for 14 days no matter what their test result is. And so this is really for people who we want to get back into school. So for our people in quarantine, we refer them to our regular PCR testing or other testing sites in the county. Next slide, please. So just so you have an idea of what the ID Now test machine looks like, here is a picture. So it's actually the dimensions. It's by about 1 foot by 1 foot by 1 foot. It's kind of the size of a large toaster. And so the specimen test collector will just collect either a nasal or a nasopharyngeal swab from the patient, and then they stick it in the machine, twirled around. And then 15 minutes later, they have their test results. And so that's how people come to the testing site by appointment. We make sure that they're all physically distanced, and that's why we have appointments. And then they can walk out 15 to 20 minutes later with a test result. And we also report that into the New York State eClair surveillance system, so that is a notifiable disease. Next slide, please. So we are also doing antibody testing in Erie County, which is not a diagnostic test. An antibody test demonstrates if people have been infected with COVID-19 in the past. So it's really evidence of a prior COVID-19 infection. So that requires a blood draw in the arm. We offer this to Erie County residents age 11 and older. The results are mailed back to people within 7 to 10 business days. It's not that they need this information to get back to work. It's not critical information like a diagnostic test. And then we rotate sites, locations throughout Erie County. So we're, everywhere by the end of the month. And this is a picture of me posing with our specimen collection for team for our antibody testing. Next slide, please. So, since we can only do a limited amount of ID Now tests and PCR tests, what we've developed for Erie County residents is a service with an interactive map that lists all the testing locations for antibody and diagnostic testing in the county. So it's a searchable map, and it's on our Erie County website at erie.gov/COVID test sites. Next slide, please. So each of the dots corresponds to a testing site, and when you click on a dot, it will give information about the testing site, about what type of test it offers, and if you need the hours of operation, if you need insurance or not, where the location is, and what type of test they offered. If it's a drive-through clinic, which many of the PCR testing clinics are, all our PCR testing clinics are drive-through clinics. And whether you need a prescription from a healthcare provider, or insurance, or an appointment. So that's we able to refer people to that testing site has been very helpful. Next slide, please. So these are informational resources that are available on our website if people want to go back and look at them. So that's all I have for now, and I'll turn it over to our next speaker, Sharita. Thanks.
So good morning. So I'm representing Westchester County. And as you may remember, Westchester was actually the first county in New York outside of New York City to have a COVID positive case. And we're going to talk a little bit about the progression of testing that has occurred since those early days back in early February and March. So next slide. So our initial introduction to COVID was through U.S. travelers returning from China following the federal travel ban. And at that point in time, we did have a couple individuals who came in from China who were quarantined, who did require testing. And if you can remember back then, we didn't even have staff trained to wear PPE, or very limited staff available to wear PPE. No labs in New York State were doing COVID testing. The only labs that could run these tests were CDC, and there was very strict requirements as to what specimens they would take. So essentially, you had to have traveled from the impacted parts of China, or been a contact to somebody who had became ill and had traveled to China. So when we had an individual who was in our quarantine process who demonstrated symptoms, we had to figure out how to get her tested, how to get this person tested, and get those specimens to CDC. So that meant putting some of our staff into PPE, sending them into the residence where the person was in quarantine, collecting the specimens, then sending the specimens to Wadsworth after we had obtained permission to be able to even run the test, to send the test, and then Wadsworth sent the specimens to CDC because there was no local testing available. Next slide. So if we progress then to early March, on the morning of March 3rd, about 1 o'clock in the morning, I received a call that we had our first case in Westchester, first case of COVID, positive COVID. This was only the second case in New York State. The individual was hospitalized in serious condition, and this immediately set into motion, unfortunately, since the person was not able to actually have a conversation with us, had to reach out and have contact with the family to try to determine who this individual might have exposed to COVID, and to try to get those people into quarantine and get testing started. This first case generated for us more than 1,000 contacts and did become the epicenter of the US epidemic early on. Next slide. So we had to do our first specimen collection in private homes. CDC sent a few their epi staff to New York. We had staff from New York State Department of Health coming into Westchester. But mostly when we started, it was our public health nurses in PPE being driven as a team to private homes and going into individuals' homes who had been identified as contacts and obtaining the swabs in the private homes. Then those specimens were collected at our clinic in White Plains and actually couried by the state police through various counties, making their way eventually to Wadsworth. And the specimens were processed and sent to CDC. So initially, all of this happened. It was very difficult to get specimens even done, very difficult to get them transferred. And later, Wadsworth was able to start doing the specimens for us, so with them no longer having to send them to CDC. But this process was taking about a week to get the results back. Next slide. So to set up the first drive-through testing site in New York State. This started on March 13th at Glen Island, and people did have to make an appointment. The criteria to be a given appointment was pretty rigorous. You had to be exposed, you had to have symptoms, it was, as I said, the initial drive-through site. I think as an initial site, this worked really well. The model has worked well for us. And next slide. As a result of this, on March 24th, there was an expansion of our drive-through facilities by Westchester Medical Center, giving us a second location within the county. Westchester has about 1 million people, and Glen Island was just not enough available appointments to meet the needs. So Westchester Medical Center stepped up to the plate. We started doing an expansion of our drive-through at that location. Next slide. So in April, as a result of all this testing, we did have a number of people that we knew from the initial exposure of those 1,000 people that had been placed in quarantine. We did know that we had about 149 people eventually who would be eligible to provide convalescent plasma. And so we began a convalescent plasma study looking for antibodies to COVID-19 in the hopes that this plasma could be used to benefit or to treat people with critical cases of COVID-19 who were hospitalized. Next slide. So Westchester's part in all of this was to work as a collaborative agent with the State Health Department and the New York City Blood Bank. We helped develop the survey questions. We helped determine the eligibility of individuals willing to donate from their test results, and ensuring that they did have a positive COVID test in the past. We contacted and recruited the participants, collected the blood samples, transported them to Wadsworth for analysis, and communicated the test results to the individuals. And we found that if we waited about 3 to 4 weeks after their initial positive test results, we could get about 80 to 90% of the specimens actually demonstrating positive antibodies. Next slide. So until this time, as I said, we had been dependent on Wadsworth to be able to run any of our tests. But by the end of June, our own labs and research were able to run PCR tests. What this allowed us was to no longer have to transport our slides all the way to Wadsworth. It allowed us to have same-day results. The lab was using a Cepheid molecular test. Unfortunately, it does provide a limited throughput because we're dependent on the amount of reagent that we have available. Unlike Erie, we don't have an endless supply of reagents, so we do have to be careful in selecting the individuals that we use for our labs and research. To date, we have tested about 720 specimens through this lab. Next slide. So the type of facilities that we have tested, since we do have a limited availability to test individuals with the county labs and research, we wanted to make sure that the testing that we did really gave us the best use of this facility. We did end up testing 11 assisted nursing homes. And what we were doing was testing nursing homes where we knew we had positive individuals, or we presumed that we had positive individuals, but they were not able to get testing at other locations. We assisted New York State in actually doing some testing in long-term care facilities, 7 locations with them. We've used this facility for a lot of what we call our O groups, our Office for people with developmental delay, our Office of Mental Health, our Office of Children and Family Services, individuals in their residential care facilities that were symptomatic. We have used this lab to try to determine whether or not we had outbreaks, and we have tested at 24 locations. We have used it in homeless shelters. We have tested it in both private schools and public schools, at least one house of worship, and we have a large group that we are actually going to be testing tomorrow at one of our local colleges. Next slide. So this grid kind of shows you the type of facilities and the number of tests that we've been able to do between our availability to use Wadsworth and our local lab. So we've tested a large number of people in assisted livings, long-term care, group homes, shelters, and schools. And so pie chart kind of demonstrates the type of facilities that we have been able to personally send our nursing staff in and do testing. Next slide. And so what has this testing demonstrated to us? Well, we have a rather high positivity in our assisted livings, but we have to be reminded that there is a sampling bias here, because we didn't test in assisted livings where we were not concerned that there was an outbreak. So these are assisted livings where we knew that we thought we had COVID cases. But I think just having the availability of having our very own lab within our county has been huge in our ability to respond to these potential outbreaks. Thank you. Next slide. Sorry, I'm right next to a hospital. So we have a large number of test sites that are not run by the health department. Where we're not using our nursing staff. And this is an online map of the available testing sites in Westchester. Next slide. So if you go to this online location and you click on one of the dots, it will, if there's a car, it indicates that it's a drive-through location. And when you click on these, it will actually give you the name of the location, their address, what type of testing is available, the number where you can call to make an appointment, what their hours are, among other information. Next slide. And as I said, this is on our website. So if you go to westchestergov.com and you can find the coronavirus testing location, just click on that and it will provide you with this information. And so I think that for us, just having the ability, I know a lot of the counties within Westchester don't have a lab within their county. I would say that having a lab has been tremendously advantageous to us in trying to keep track of emerging outbreaks, emerging clusters within our community, being able to get the testing done rapidly, knowing who's being tested, and having same day or close to same day accessibility to the results has really improved our ability to respond to these types of events. Next slide. So just want to thank you. And I turn it over to the next speaker.
Hello. Hi, everyone. So I'm going to talk about a little bit different strategy that we've been using at Syracuse University. And so I come to this presentation from a little bit of a unique perspective in that I don't have a clinical background. My background is purely in public health, and so we're going to focus more on the surveillance testing as opposed to the clinical diagnostic testing that we're doing at Syracuse University. So next slide, please. So Syracuse University is a private research university located in Onondaga County in upstate New York. And one of the main factors that we looked at before inviting students back to campus was the county level transmission dynamics. And so that's really important in that we had low level community transmission in Onondaga County due to the excellent work of our county health department before the students came in, and that has, I think, contributed a lot to our so far success. It's not quite October, we still have a while to go, so don't want to count our chickens, but it was really important that there was low level of county transmission of SARS coronavirus cases in late or early to mid-August. Currently, there have been 202 deaths in Onondaga County. When we invited the students back there, I think had been under 200 current deaths. So next slide, please. So we implemented a mass testing campaign and several different types of mass testing because we recognized that bringing students into this county from all over the country presented a great risk not only to our students, faculty, and staff, but to the surrounding community due to the risk of travel-related disease. And so we really wanted to make sure that we could minimize transmission among our students and prevent that as much as possible from getting out into the community. Next slide, please. So we had a three-pronged approach to our mass testing. So we had a pre-arrival testing where the students needed to submit proof of a negative COVID test before they came to campus. Arrival testing, so as they arrived during move-in, we gave them another test. And then post-arrival screening, so 2 weeks after arrival, we plan to test the entire student body, which we did, and then we have several more planned of the entire student body throughout the semester, as well as whenever contact tracing or other signals warrant mass testing. Next slide, please. So our pre-arrival testing, we since we made students submit proof of a negative test, they could go if their local community had the capacity or their local doctor's office had the capacity, they could go to a provider of their choice and get a negative test. It had to be within 10 days of their arrival on campus. Or we also offered this Let's Get Checked test, which is a nasal swab test that could be administered by the students themselves and then mailed in. Due to the New York State travel restrictions, we did have quite a few students coming in from hot states, as they are still called. And we were able to provide on-campus quarantine housing for our freshman students. And so we did look at the pre-arrival testing results of the about 450 or so first-year students who took advantage of our on-campus quarantine. And we found that over 1% of them actually had tested positive on this pre-arrival screening. So they were not able to come to campus immediately. They had to follow isolation protocols before they could come to campus and come into New York State. But that's actually quite high when you think about this, right? 1.2% of asymptomatic healthy students tested positive for the coronavirus. And so it's really concerning when we start thinking about a lot of the other colleges and universities who did not require a pre-arrival test about the number of infections, right? So that was 450 students. About 5 students would have come in from just our freshman first-year students who used the on-campus quarantine, would have come into New York State with an active infection. And so we think about the one student or the one person who had over 1,000 contacts, right? So hopefully we wouldn't have 1,000 contacts, but that's a lot of people that we would have had to contact trace. And so we think that this pre-arrival screening was really important in eliminating several chains of transmission before the students even arrived. Next slide, please. And so then our arrival and post-arrival testing, we've been using this pooled saliva test run out of Upstate Medical University, which luckily for us is right down the street, about 2 blocks away from us. And so if any of you are working with the SUNY systems, they're using this test now as well. And so it's a self-collected saliva swab. So the students are able to use the saliva swab and just put the little sponge in their mouth and collect a sample. And then we send them down the street for the PCR testing in pools of about 12 students using this test developed at Upstate Medical University. Next slide, please. And so we've been really depending on a lot of students to help make this system work. And so what we do is we actually have Syracuse University students process and pool the samples before we bring them down to the lab for a PCR test. And so what pooling does is it combines several samples together into one test. So say, for example, the lab has the capacity to run 100 tests a day. It has a lot more, but just for the sake of simplicity. So we could test 100 students in one day, or we could do pools of 12. So we combine 12 students into one pool, and now the lab can run 1,200 samples a day. And so this is not really a new technique. This pooling is pretty common practice. The Red Cross, for example, does this with all of our blood. Whenever we donate blood, they pool little portions to test it for HIV, hepatitis, other infections. And so this is pretty common when you expect there to be low prevalence. And so as long as the transmission dynamics in your community or in your university are low, this is a very effective strategy for testing healthy people. So people who appear to be healthy, people who are asymptomatic. Next slide. And so far using this saliva screening test, we've administered approximately 40,000 saliva tests since August 2nd, and about 1% of those tests have been, or 0.1%, sorry, have been positive. And so we've been able to identify several infections this way and prevent them from being out among their students in the community much sooner than if we had waited for them to develop symptoms, and some of them actually never did develop symptoms. So this was a way to identify those infections. Next slide, please. And so we've also been using a lot of contact tracing, and so we have about 40 or so student contact tracers. So the most effective contact tracers are the ones who are part of the community, and so they're able to help us identify potential contacts. And we've actually been able to optimize a lot of our contact tracing in that in the last few rounds of saliva testing, many of our students that we've identified as cases have already been in quarantine. So they were identified as positive people, or as they were identified as contacts of previous cases and had been put into quarantine before we actually got our test results back. So we've been really able to optimize a lot of our contact tracing efforts, using students to actually do the calling and do the contact tracing in close communication with the Onondaga Community Health Department. Next slide, please. And finally, one of our other methods of testing has been wastewater testing. So we actually have been testing the wastewater of several of the dorms around campus. And so again, while wastewater testing may sound new, it's really not that new of a technology. We've been using it to monitor poliovirus transmission in developing countries for decades. And so in the case of polio, when you find, again, right, many people who are infected with polio do not have symptoms. Many of them will just have a gastrointestinal illness, and that's not very specific. And only very few of them will actually develop the paralysis that were associated with polio infections. And so if we wait for a case of this paralysis to present to the health department, polio has already been circulating in the community for weeks or even months. And so now it's too late to be able to institute a vaccination mop-up campaign to try to prevent more cases. And so we can use this wastewater as an early warning signal. And so we've been doing this in our dorms at the dorm level to again try to find any potential positive people before they're able to spread to their classmates and their dorm mates. And so every case that we find is a victory against this virus before they can transmit it to many people. Next slide, please. And so again, we use a lot of students in this process. And so here we see some pictures of where the auto sampler is. So we collect a 24-hour sample from these streams outside the dorms, and then we process them and run a PCR test on them to see if we can detect parts of the coronavirus RNA. Next slide, please. And so here we're looking at the dashboard at Syracuse University. So this is a public-facing dashboard. Anyone can check it out. I pulled these slides yesterday in this, or these images yesterday. The dashboard is updated on a daily basis, so it might look a little different if you want to go check it now. But we currently have 10 active infections among people affiliated with Syracuse University. So that will be students, faculty, and staff within the Central New York region. And then we are also monitoring cases away from Central New York. So students were given the option to do a fully online, fully remote semester if that's what they decided to do. Next slide, please. And so here's some more statistics about what we've done. So counting diagnostic tests done on campus by our campus medical facility, along with the saliva tests, we've administered over 50,000 tests since the beginning of August. We currently have, as of yesterday, we have 145 students in quarantine based on the contact with either active cases or recently active cases, recently recovered cases. We continue to monitor the situation and update the public. Next slide, please. And so I just want to thank a lot of the people who contributed to this. So these are some of the, so Dr. Larson is another professor here. Caitlin Mogan is a graduate student and one of our lead contact tracers. And then Madeline Mikowski and Prithvi Kalaru are recent Masters of Public Health graduates from our program, and they've been really spearheading a lot of these mass testing campaigns. Of course, we have a lot of other people to thank, Dr. Frank Middleton at Upstate, all the contact tracers, and the Onondaga County Health Department as well. So next slide, please. All right, thank you very much. And I think we're gonna open this up to questions now. Thank you.
Yes, thank you all so much. Those were all really excellent presentations, and I think I can speak for everyone on the line when I say that I learned something from all of them, so thank you. Our audience has been very engaged throughout and they've submitted a number of questions. If you do have questions that you haven't submitted yet, we encourage you to type them into the GoToWebinar platform. You can find a panel on the side of your screen where you type in your questions, and then we'll read them aloud at this time. So to kick things off, the first questions we received were about the Abbott ID Now test. They ask, is the Abbott ID Now test going to be the new standard in testing, and are there any age limitations for these tests?
So sorry, is the second part of the question, are there any what limitation? Age?
Yep.
Oh, right. So the Abbott ID Now test is actually another testing option that we have in Erie County and New York State. So it is the advantage is, as I mentioned, that it's a CLIA-waived point of care test. So it's a rapid test that can be done in the field. You don't have to be a clinical laboratory to operate it. It's pretty simple to use. It's more sensitive than the antigen test. However, it's more expensive. The machinery to purchase is more expensive. The test kits are more difficult to obtain, so that there is competition in the market for that. New York State Health Department has been very generous in supplying us with the machines and test kits for now. Eventually, we'll be on our own. We'll have to cut those apron strings and figure out what to do. However, they have been very helpful, especially when people need their test results right away. And we've been focusing on students and staff in schools. So also the antigen tests, I think, are the test that is on the horizon that I think many private offices are looking to obtain. The antigen test is a test that has been used by primary care providers and other providers in the community to diagnose other infectious diseases, like the flu test that we do. That's an antigen test, a rapid antigen test, and that many primary care providers have that in their office already. There's also like rapid strep tests that are frequently used at primary care providers. So we have a history of using those in primary care. Again, the disadvantage is that they're not as sensitive as the diagnostic molecular test. So a negative, if you're strongly suspicious, I think I would order a molecular diagnostic test to confirm it, just like we do with rapid strep tests. If your rapid strep test is negative, they send it for a confirmatory culture, which is a much sensitive test. So I think it kind of depends on where the situation is, where you are, but obviously people want to know their test results right away, and so the more availability we have with rapid testing, I think will be easier for us to return back to the workplace or to school or to wherever we have to be. We just have to acknowledge what the limitations of all those testing technologies are. And this, in terms of for any of the tests, I'm not aware of any limits on the age where kids can get tested. Actually, this morning we tested a 9-month-old with our ID Now test who needed a negative test to be seen at the Cleveland Clinic for specialty care. So and we have also tested, infants with our regular PCR. So pediatrics is a go. You can do it with kids. Thanks.
If I could add something to that, I would say that I agree with Gail that if you have a negative antigen test, you should go on to have a PCR test just to confirm that if possible. But if the antigen test is positive, stop there. There's no need for a PCR test once you have a positive antigen test. Some people seem to think it will get them out of quarantine or isolation, in the case of when their test is positive. But a negative test won't get you out of quarantine, and once your antigen test is positive, it's positive, and you're in isolation. And no matter how many subsequent tests you have after that that are negative, we have to go with that positive finding. So just
right. So all the tests are very specific. They have high specificity. So a positive is a solid positive. You just have to worry about the negatives that you might be missing something.
Absolutely.
Thank you both. This next question we received is specifically for Dr. Brittany Kamish. How do the Syracuse University contact tracers interface with the Onondaga County Department of Health?
Yeah, so they actually have to report back to the Department of Health every day, give some sort of report to them. I've been more focused on the saliva testing, so they're not my direct group, but yeah, they have a report. We have several people from the county that they communicate with on a daily basis, and the head of the contact tracers has been in strong communication with them to make sure that everything is communicated clearly and frequently.
This next question is for both of our health commissioners. How often do you advise the average resident to be tested, and will this guidance change as we enter flu season?
I think that for us, you know, if the person has a reason to be tested, we certainly would encourage it. So let's say that they've had an exposure to someone who's tested positive for COVID, or they're symptomatic of that. But a lot of people are tested for other reasons, like they have a doctor's appointment or some other kind of appointment where they cannot attend that appointment unless they can demonstrate a negative finding. I think, you know, the more testing that is available, the easier it is for us to know what individuals are of concern and allow us to rapidly put contact tracing in place to try to contain the infection.
Oh, yeah, I completely agree with, you know, especially people who are concerned they have an exposure or people who are symptomatic. You know, it's really important to tell if they have COVID-19 or not, so we can implement contact tracing and stop the chain of transmission in our community. That's really the only way we can get our numbers down. And it's really challenging now that we're coming upon flu season because, and respiratory, we call them pediatrics, respiratory crud season, where many respiratory viruses present the same as COVID-19. And unfortunately, the only way you're going to know if you have COVID-19 or not is to get a test. So we anticipate an increased demand, especially among school-age children that want to get back into school as they develop respiratory symptoms, as they typically do in the fall and the winter, that there'll be an increased demand for testing overall, which we're worried that the healthcare, you know, that our healthcare community may not be able to meet that need.
So that just bodes the fact that we need everyone to get their flu shot. Please encourage everyone you know and care about, get your flu shot this year. Reduce diagnostic confusion. So, you know, if you've had your flu shot, you're less likely to have influenza. Allows your physician to be more concerned that you might have COVID.
And you can have both at the same time.
Which we also don't want to have happen.
So this next question segues nicely. Are New York's counties and universities prepared for a possible second wave, and what does this preparation look like at the local level?
Well, I think as we've talked about already, you know, the best way to prevent any kind of resurgence of the virus is by being able to identify those that are infected, isolate them, identify their contacts, get them into contact tracing, get them tested, and try to prevent cases from occurring through quarantine. So if people, unfortunately, not everyone listens. We have individuals that are placed in quarantine and then they decide to go out and party with all of their friends. We really have to educate the public what the importance of quarantining is. We're not trying to hamper your social life. We're trying to stop a disease from spreading. And this is how we do it. And so identify the cases, identify the contacts, isolation and quarantine, and testing. That's really how you prevent this.
Right, and this is, you know, I agree with Dr. Amler. It's very well said. Thank you. I mean, this is really a continuum because we're already doing the work to try to prevent, and by changing our behaviors with wearing a mask, social distancing, washing our hands, making sure that frequently touched surfaces are disinfected, people getting tested that are at risk or who have symptoms, and then also very importantly, as Dr. Amler beautifully put it, that with the contact tracing, with identifying cases, putting them into isolation, removing them from the community, identifying who their contacts are, putting them in quarantine, removing them from the community during the incubation period, and breaking the chain of community transmission. And so at this fall and winter, we're going to have to ramp up all those activities, and we really depend on our elected officials to help us with this as much as possible. The messaging that you provide is key to help us meet our goals with keeping our numbers down. And every message helps. I mean, and from multiple different sources, people need to hear it from every different source. So not just from the healthcare or the public health community. Our elected officials are in this with us. You want everything to open up just as much as we do. You want to keep the numbers down, and we really need your support with the messaging. Powerful, strong, loud messaging. Scream it.
I agree with Gail. You're a trusted source, and we really need everyone. We need everyone to come together and understand how we get out of this. And I think Gail said it beautifully. It's all of these things. There isn't one bullet. There isn't a magic bullet. We have to do all of these things, and we have to continue to do these things. And I know people are tired and they want this to go away, and they don't want to have to wear a mask or social distance or wash their hands or be in isolation or quarantine. But this is what we have to do if we don't want to go back to the days where in Westchester we had more than 1,000 cases a day. I don't want to see those days again. So we really need to educate everyone, and we have to continue the fight until this is gone.
Thank you both. The next question we received is, if you are contacted by a contact tracer, how long should you wait to be tested, because the RNA does build up over time?
There was an article published about a month ago in the Annals of Internal Medicine that looked at the proportion of false negative results, like over the time course of infection. And what they found that the time, and this is looking at older studies that had already been published. And so what they found from these other studies is that it seemed like the day of infection with the smallest proportion of false negative tests was day number 8 of infection. And so if people were symptomatic, that was day number 3 of symptoms. They assumed that what they found is, many people who developed symptoms became symptomatic on day number 5 of infection, and then the day number 8 of infection, or day number 3 of symptoms, they had the lowest proportion of false negatives. But everybody's different, and if you can get a test, and because you need it, you should get one. But however, if you think like, oh my gosh, I was just exposed, I could have been exposed yesterday at this party, don't get the test tomorrow, because it will be negative and it'll give you a false sense of security. So you just want to wait a little time for that viral load to build up, so that we will be able to detect it.
Totally agree with everything she said. She's absolutely dead on right. So we really encourage people to wait. We say at least 5 days, but at any point, if you're symptomatic, get tested.
This next question is for our whole panel. How important is COVID-19 testing relative to other disease control measures like contact tracing, wastewater surveillance, and mask wearing?
Well, I think testing is really important, especially as we start moving into flu and respiratory crud season, as it was called earlier, right? So we want to make sure that we identify people who have COVID, and the symptoms are the same as most of these other respiratory diseases. And so we need to test them to make sure that we identify who they are, so we can initiate the contact tracing. But again, it's only one prong, right? We need to do the social distancing and the mask wearing to also prevent that, because there are people who don't develop symptoms, or you can get the disease and have transmission from people who are pre-symptomatic, so people who haven't yet developed symptoms. And so these are all things that we need to do, so that not one is any more important than the other. They're all very important to do to control the spread.
Right, testing is really, our key strategy, our core strategy for secondary prevention. So primary prevention, preventing the disease from even happening. So that's the wearing masks, no social distancing, washing your hands, cleaning frequently, touch surfaces. And then secondary prevention would be finding people who are already infected and their contacts and removing them from the rest of the community to break the chain of transmission. So, we have these tools in our toolbox. Testing is an important component. However, all our components are very important, and we have to adhere to all of them, both primary and secondary prevention.
And just a reminder that, now is really not the time to be getting into large groups. I mean, for us, some of our major problems are when we have someone who's infectious with COVID, and they've been in a very large event where they've had contact with many, many people. And then you're having to outreach to, 50 people at one time. So just a reminder that large groups is especially important still to maintain social distancing, still to wear the mask. All of these things count, whether you're in a group of 5 or you're in a group of 100. Just a reminder.
Thank you all. The next question, are pool testing results entered into the electronic clinical laboratory reporting system, specifically for SUNY schools?
I don't know what SUNY schools are doing. The pool saliva testing when they're reported to New York State Department of Health, are not reported in the clinical testing. And so if a student is positive on the pool test, then we do have them go get a clinical test. So those would be included in the clinical tests. But the pool saliva or surveillance testing is a different category for the New York State Department of Health. I don't know specifically what the SUNY systems are doing, but I do know for the Department of Health, it's a different category.
Yeah, we haven't, from the University of Buffalo, we haven't received the test results for the pooled specimens. However, when there is a positive pool, those individuals in those pools are recommended to get, do receive reflex testing. And so those test results are entered into eClaires.
Are there differences between the colleges that did surveillance testing and those that did not?
Yes, I mean, now all the SUNY schools have to do this surveillance testing. I believe most of them are all doing it through the lab at Upstate University, or a lot of them are, at least the ones that can get to Upstate New York in a relatively short amount of time. But the New York State Department of Health kind of really left it open as to what kind of testing strategy each university would like to do. They had some guidelines, but it did not include, arrival or pre-arrival screening at first. But now the guidelines for SUNY schools have changed. I don't know exactly what they are because Syracuse University is not a part of the SUNY system, but they have changed and they are more stringent now.
Thank you. Is lab capacity still an issue in New York State, and what can be done to increase lab capacity across the state?
I think for us, it's more reagent. The availability of the reagents to run the tests have been a problem in Westchester. But I will say that with a larger number of people being tested, requesting testing, it seems to have increased the amount of time it takes for people to get their test results. So the individuals who are going to our medical facilities and getting testing for a while there, they were getting their PCR tests back within a couple of days, and then it went to a week or longer. And I think it's now moving back towards closer to 3 to 4 days. But it seems very dependent on the number of people being tested as to how fast we are able to get their test results back.
Okay, we'll take 1 or 2 more questions here before you wrap up. The next question is, what do you advise residents to do who want to be tested but don't want to be surprised with a bill from their insurance company?
Well, many areas have, free testing available for the New York State Health Department. If you Google the New York State Health Department COVID-19 hotline, You can call them and find out if there is a testing site nearest you. Also, some local health departments, like our local health department, offers free testing to Erie County residents, so that can be an option too. And then some of the the FQHCs and other healthcare providers are offering testing. So people who are insured would need to talk to their health plans to find out if it's covered. In general, in our area, I think if it's a test for like a diagnosing somebody who has an exposure or somebody who has symptoms, the health plan said that they would cover it. It's really for the health plans have told us they're not going to cover like surveillance testing, or if people don't have a really good reason. So I think if our healthcare providers are creative and smart about putting on their, about what type of, billing and diagnostic codes they use, hopefully most of those tests can get covered.
Great. We'll do one final question before we wrap things up today. What is the timeline for making rapid at-home testing available to New Yorkers? And is this still the end goal, or is it something local health departments are preparing for?
I'm afraid I don't have an answer for that. I would love to have the crystal ball to know that answer, but I really don't.
Yeah, I mean, there are disadvantages and disadvantages with home testing. So the advantage is that, people will be able to test in the privacy of their own home and get the results quickly. The disadvantage is that this is a communicable disease, right? And so it will be difficult for the health departments to step in with disease investigation and contact tracing if somebody tests at home and then does not disclose their results. So, so this really could create a challenge for the public health system.
And then I would have concerns about the sensitivity and specificity of those tests. And, we already have enough issues around that. So I'm not totally sure it's in the best interest of the public, but that's a decision beyond me. But I totally agree. I think part of the concern is we to manage this, we need to have some idea of who needs to be placed in isolation and who needs quarantine. And I'm not sure that people would actually give us that information if they were doing the testing in their own home.
Mm-hmm. Well, thank you all so much for attending this virtual NYSAC Fall Seminar Workshop about COVID-19 testing. Special thanks to our speakers, Dr. Gail Burstein, Dr. Sharlita Amler, and Dr. Brittany Kamish for joining us and giving us these excellent presentations today. And thank you also to our sponsor, United Healthcare Retiree Solutions, for sponsoring this session. You can find a recording of the webinar and a copy of the slide deck you saw today on our website. It's at nysac.org/fall seminar. We hope to see you at our final virtual fall seminar workshop about educating during a pandemic tomorrow at 2 p.m. Thank you all. Take care.
Thank you.